Hello, everybody. A warm welcome to today's episode of BrainPet Talks. These talks are supported by Positrigo, which is a pioneer in nuclear medicine imaging technologies. Today's episode is about diagnostic pathways for Alzheimer's disease and the importance of BrainPet, and we feel honored to have Dr. Devous with us today. Dr. Michael Devous is president of MDD Enterprises, a medical and scientific consulting company. He also currently serves as chairman of the board for the Alzheimer's Association New Mexico chapter. He was vice president of imaging at Avid Radiopharmaceuticals, a wholly owned subsidiary of Eli Lilly and Company through May 2021. His responsibilities included serving on the executive committee, directing the imaging sciences department, and designing, executing, and analyzing clinical trials. He was also previously professor of radiology, neurology, and bioengineering, director of the Alzheimer's Disease Center, Neuroimaging Core, co-principal investigator of the North Texas Traumatic Brain Injury Model System, and associate director of the Nuclear Medicine Center at the University of Texas Southwestern Medical Center in Dallas. He has authored more than 200 peer-reviewed articles, 380 abstracts, and 30 books or book chapters. Dr. Devous is past president of the Society of Nuclear Medicine, the Education and Research Foundation, and the Brain Imaging Council. And last but not least, he is a former chair of the Food and Drug Administration Medical Imaging Drugs Advisory Committee. Dr. Devous, thanks for being with us today. The floor is all yours.
Thank you very much. As noted, I'm Mike Devous, and I have the opportunity to give you this presentation on diagnostic pathways for Alzheimer's disease and the importance to those pathways of brain PET. This is a model of Alzheimer's brain pathology, and you can tell it's quite complex. It's multifactorial with a big focus on amyloid pathology and tau pathology. Their entry points are noted by the red circles. And then probably next in line in terms of the targets of interest are targets of neuroinflammation associated with astrocytes and microglia. And then finally, the capillary component, which is associated with extensive vascular disease, seen in almost every patient that comes to autopsy with Alzheimer's disease. And these all interact with each other, unfortunately, in feedback loops that aggravate the destruction by each pathway. The key then is to try to interrupt these pathways as early as possible in the disease course. And the question then is, how do you get to an early diagnosis? This is a cartoon I made years and years ago of the diagnostic process and how clinical symptoms are related to imaging biomarkers. What we have available to us mostly is the typical published data. That's data obtained in patients with well-confirmed diagnoses. By the time you have a well-confirmed diagnosis, unfortunately, your symptoms are pretty severe and you're relatively well removed from the symptom onset time. There is some limited so-called early data in patients characterized as having early Alzheimer's disease or maybe mild cognitive impairment. But what we really want to get to is this prodromic population at the very beginning of symptom onset, or possibly even earlier. And that's where neuroimaging comes into play. We are able to move the diagnosis earlier and earlier in the process, at least at the time of symptom onset, and in some cases, particularly with amyloid, even as much as a decade or two prior to symptom onset. That has changed the landscape for the treatment of Alzheimer's disease. This very busy plot was an assembly by Jeff Cummings of all of the drugs in phase 1, 2, or 3 clinical trials associated with trying to treat or modify Alzheimer's disease. The upper third here, this one labeled as disease-modifying biologics, has been the most productive, with 3 drugs reaching phase 3 successful trials. Aducanumab and lecanemab are FDA approved. Donanemab from Eli Lilly is likely to be approved sometime this year. Just needs to go before an advisory committee. And then there's a whole lot of small molecules that are targeting a lot of pathways. I took this little box up here and enlarged it so that you could get a sense for what pathways are being attacked, and primarily being attacked because we have ways of measuring these in vivo through primarily PET imaging. So everything with a red dot is an amyloid target. Lots and lots of red dots on both the disease modifying and the biologics and the small molecules. And tau are the blue ones, and you can see there are lots and lots of blue dots here. And probably the next most common color up there is yellow, and that's the neuroinflammation target base. So there's a lot of activity here that PET imaging has opened up. And that's because of the cascade that occurs as onset of Alzheimer's disease is present. So what we see here is the very first thing that goes south, if you will, is beta amyloid. It is at a normal level for a long time and then begins to rise in the preclinical phase of the disease. And that's detected by PET primarily these days, can be detected in cerebrospinal fluid, and there are even blood-based biomarkers that are focused on detecting beta amyloid. The next event in the cascade is tau. Tau neurofibrillary tangles, which are intracellular protein misfolds that aggravate the disease and are probably most tightly correlated to cognitive impairments. And that's detectable now by FDA-approved tau PET imaging agents, and also can be detected in cerebrospinal fluid and by blood-based biomarkers. Then you get changes in cognitive behaviors, not cognition itself, but behaviors, represented by changes in glucose metabolism or seen on functional MRI studies. All of that is associated with cell death. And as we move from the preclinical phase to mild cognitive impairment, cell death increases, you get atrophy as seen in structural MRI, cognition goes from normal to impaired mildly, and finally severely impaired as you get the onset of pure dementia. And the difference between mild cognitive impairment and pure dementia is the clinical impairment. We say that people have abnormal cognition and abnormal function when they are actually demented. The time course for these changes is impressive. Amyloid begins to increase a decade and a half to 2 decades before the onset of frank symptoms seen in MCI. Tau also occurs early, probably 5 to 10 years before mild cognitive impairment is detectable, as a clinical exam would identify a patient as being mildly impaired. Then you get the degeneration seen in structural MRI. That is always present in mild cognitive impairment. And finally, cognition declines until you get into full dementia. And the total time course from the onset of positive amyloid scans to full course dementia can be 30 years, as you can see in the x-axis of this plot. That leads to the question of how does PET imaging impact our understanding of Alzheimer's disease and the conduct of Alzheimer's disease clinical trials? Well, there are 2 major unmet needs that we can address. The first is, who should we treat? That is, to use these scans as a marker for patient stratification or enrollment. Obviously, if you're going to conduct an anti-amyloid therapy clinical trial, you need to be sure patients have amyloid. So you do a PET scan to identify the presence of amyloid plaques. Then you ask, how do you know if the drug is working? If you do a study and the treatment takes amyloid away, you know you've treated the marker, the biomarker for amyloid, but you don't know if you've actually changed the course of the disease. So you could use another PET tracer, such as tau, to see whether you're changing the disease course by altering amyloid production. This can go in both directions. You can do amyloid PET for patient stratification, certainly, and tau PET as a surrogate marker for disease modification. But if you're doing an anti-tau therapy, then tau becomes the patient stratification marker and amyloid the surrogate marker for efficacy. And that's the way they're being used today. That is to say, we have kind of moved into a new diagnostic paradigm, the neuropathological diagnosis of AD. Prior to this opportunity, confirmed Alzheimer's disease was only obtained by an autopsy examination of the brain. We only had clinical techniques that were honestly in error 25 to 30% of the time. So you went to an autopsy to identify the presence of Alzheimer's disease. Now that we can image it or measure it in CSF, we have moved into an era in which we consider the diagnosis of the disease to be based on these biomarkers, a neuropathological diagnosis. There's a lot of stuff on this slide. I just want to point out three things. There are ways to assess amyloid by neuropathology, by autopsy, and by brain PET that allows us to score patients into different thal phases or CIRAD plaque scores. And the same is similar for tau. There are the so-called B scores or Brock stages. And when patients achieve a high CIRAD score and a high Brock score based on amyloid and tau PET imaging, you can be sure that you have a positive diagnosis for Alzheimer's disease. Amyloid is positive, tau is positive, and if you do functional or structural MRI, you get neurodegeneration positive patients. And that's the way we diagnose patients today, ante-mortem. The big change, of course, is access to both amyloid and tau, and I want you to get a sense for how this progresses. On the left-hand side are summary scans of young cognitively normal controls showing essentially no tau present. By the time you get to older subjects who are positive for amyloid, but still cognitively normal, and you see tau beginning to develop in the temporal lobes and the inferior margins of the frontal lobes. At the time patients are diagnosed as having mild cognitive impairment and they're amyloid positive, you can see that tau has spread widely throughout the neocortex. And then finally, when patients have a diagnosis of mild to moderate Alzheimer's disease and they're amyloid positive, you get this extensive distribution of tau neurofibrillary tangles. The point here is that the occurrence of amyloid and tau are linked, amyloid coming on first and tau coming on second. And Vincent Dorr made this delightful movie that I'm going to show you, showing the time course from 10 years before diagnosis. You see amyloid developing throughout the brain. By the time amyloid gets pretty high, you start seeing tau accumulate widely. And by the time you're 20 or 30 years of the diagnosis, you have widespread amyloid plaques and widespread tau neurofibrillary tangles. And that's data from PET scans in humans collected as part of the Alzheimer's trial in Australia. So can we alter these biomarker trajectories? That's kind of the hope, isn't it? If now that we can diagnose patients ante-mortem, can we do something about it? And the answer is, fortunately, yes for amyloid. That is, at present, anti-amyloid monoclonal antibodies have been the only therapy effective at attacking a specific risk factor, a biomarker, amyloid plaques in particular. Here's an example of phase 3 results from 3 drugs. On the left is aducanumab. The y-axis is, the x-axis is time in all 3 of these plots. The y-axis is the amount of amyloid, and you can see that the patients in this trial had a pretty dramatic lowering of their amyloid, really by 26 weeks, and even more so by 78 weeks. And what you can see here is their so-called Centiloid scale, CL. We developed this scale to give us a uniform way across tracers to measure the degree of amyloid present in patients at diagnosis or altered by treatment. And we get a 41 Centiloid lowering in one arm of the trial and a 64 Centiloid lowering in the other trial. If you move to lecanemab, the more recently approved drug, you can see as the placebo group doesn't change at all, this very dramatic lowering. And now the y-axis is in Centiloids, and they get all the way down to almost a 60 Centiloid lowering. An average Centiloid value of 100 is a typical Alzheimer's patient, so going down 100 Centiloids would be essentially going to 0. On the far right is the Lilly drug donanemab. It has finished its phase 3 trial with very successful results under FDA review at the moment. And you can see that it also dramatically lowers the Centiloid count for amyloid, really by 24 weeks to the level that either aducanumab or lecanemab achieved, and then continues to go down all the way out to the 18-month end of the trial. So the answer seems to be yes. We can actually use PET scans not only to document that patients have amyloid in their brain and are indeed, at least in the preclinical phase of Alzheimer's disease, but that the drug works to remove the target, it removes amyloid. How do you use these tools then to develop the right therapies for the right patients? We developed this sort of window for therapy diagram that we're using now in clinical trials. This is time on the x-axis and the biomarker level on the right. And the sort of orangey colored line is tau. And you notice that it's actually elevated pretty early. There is a certain amount of tau in the medial temporal lobe of basically every adult over the age of 45. We don't know what clinical meaning that has. It is not the same as the tau that develops in association with Alzheimer's disease over time. The thing that climbs first is amyloid, and it becomes detectable at the place of the red arrow. And at this point, patients are not yet symptomatic. And then as amyloid gets substantially elevated, it seems to induce an elevation of tau, and a simultaneous occurrence of amyloid and tau seems to mark the beginning of cognitive impairment. As cognitive impairment proceeds, increasing tau predicts that decline, and finally you get a global tauopathy that drives the disease in patients that you might want to treat. The vertical lines then might represent a window for anti-amyloid therapy. That is, you need to have enough amyloid to treat, which you do at the beginning, and not so much tau that you are in fact dominated by tau as the cause of cognitive impairment, and thus anti-amyloid drugs are unlikely to be effective. This, we think, would be the window for anti-amyloid therapy. The window for anti-tau therapies might be moved a little bit to the right, as you would suspect. Well, the first drug trial to use amyloid as a way to include patients or exclude patients is, as I showed you a minute ago, the lecanemab trial, which not only removed a lot of amyloid, but you can see slowed cognitive decline. In the primary that they used, the CDR sum of boxes, the placebo patients went down like this. Lecanemab treated patients went down. So you had about a 26% slowing, statistically significant slowing of cognitive decline. And this is a huge success in the Alzheimer's world, to be able to slow cognitive decline. These are the first disease-modifying treatments we've ever had. When we use both amyloid and tau to select patients, as was done for the Diagnostic trial, you get a scheme like this. The patients with very little tau are not enrolled at all, even if they have amyloid. And the reason here is if you don't also have tau, you're not going to decline very much over the course of a clinical trial. If you don't decline in the placebo group, you can't measure the benefit of an intervention such as an anti-amyloid monoclonal antibody. So these patients are removed. Again, patients with a lot of tau, as we see on the far right, are liable to progress no matter what you do to amyloid, because tau now dominates their clinical progression. It's this sort of sweet spot in the middle where you have low to medium tau and definite amyloid that marks the kinds of patients we think might be most responsive to anti-amyloid therapy. And indeed, the phase 3 results of donanemab seem to support that. The iADRS, which was their primary, a measure that's a mixture of cognition and function, showed a 35% slowing at 1 year. Patients on the placebo declined, as indicated in the kind of gray line. The green line is the donanemab. And statistically significant slowing of cognitive decline was seen as early as 12 weeks with this drug. This is a pretty successful trial. The CDR sum of boxes, the same measure that was used as the primary for lecanemab, also showed a 36% slowing by donanemab at 76 weeks. So we're pretty happy that this way of entering patients into clinical trials, a sweet spot for anti-amyloid therapy, may indeed be effective. So to summarize, amyloid imaging can be used to help select patients with amyloid pathology. Pretty important if you're going to do an anti-amyloid therapy. There are a substantial number of patients in AD trials without the pathology of AD. In fact, one of the first drugs that was successful, in part at least, was solanezumab, where we did not use any biomarkers to enroll patients. That enrolled entirely based on their clinical status. And about 25 to 30% of those patients after the fact were learned to not have amyloid. And indeed, when you plotted their clinical response to the drug, they remained stable over 18 months. They did not respond to therapy at all. And the placebo group did not decline either when they did not have amyloid. Obviously, we can use amyloid imaging to show effect on target for anti-amyloid drugs, as you saw with both lecanemab and donanemab. although none of the amyloid imaging agents are currently approved for this purpose. They're approved for detecting amyloid in patients at risk for Alzheimer's disease. Tau imaging can then help stratify patients for clinical trials. As you saw, particularly with the donanemab trial, it improves the homogeneity of the patients in the trial and helps identify a sweet spot where patients might be most responsive to an anti-amyloid therapy. It's also relevant to the identification of AD pathology. I didn't mention earlier, but should now, that there are a lot of people who are positive for amyloid who never develop dementia. Either they are affected by some other cause of disease and don't live long enough to develop Alzheimer's disease, or there are other underlying causes of cognitive impairment not related to AD that is associated with their decline. So it's possible to have amyloid and not ultimately end up with Alzheimer's disease. But you have you have amyloid and tau, you have the pathology of Alzheimer's disease, you will decline, as has been well studied in many different trials. So the evolution of both cognitive and functional decline in MCI and AD patients is very closely related to tau pathology, and thus to the tau PET imaging we can do these days. So using biomarkers in clinical trials have helped identify the biological targets, especially amyloid and tau, the correct patients for those trials, and ultimately then the correct patients to respond to therapy. And finally, just in the last 18 months, effective treatments. Thank you very much for your time.
Wow, thank you so much for this very interesting presentation, Mike. That's really amazing, especially what happened very recently with the availability of this disease-modifying therapy. We still have time for a few questions. We talked a lot about amyloid and tau. Now, currently available PET tracers. Can you a little bit elaborate on that?
Sure. The FDA has approved 3 PET tracers for amyloid, and they're all commercially available. They're not widely available because clinical demand until we had effective therapies has been modest at best. And there's one tracer approved by the FDA for detecting tau. And it's the same story. It's not widely available yet. It could be. It's readily made at lots of facilities. But until clinical demand is high enough, and I think that's going to be associated with effective therapies, none of these agents are in widespread use.
Okay. Now, we have obviously brain PET. We have other fluid-based or blood-based biomarkers. How do you see the impact of blood-based biomarkers going forward?
That's a good question. Let's talk about amyloid and tau separately. For amyloid, there's a pretty decent assay made by a company called C2N that measures a ratio of A beta 40 to 42 and does a decent job of detecting amyloid, though it isn't as quantifiable as a PET scan would be. I think you will see those blood-based biomarkers used as screening tools to say this patient either has no detectable amyloid and doesn't need a PET scan, or does have detectable amyloid, but we need a PET scan to identify how much and to see whether or not that patient would be responsive to therapy. On the tau side, it's a little bit different. There are blood-based biomarkers for tau. Maybe the most common now is an assay called p-tau217. They are frankly more accurate than the blood-based biomarkers for amyloid. They do a good job of detecting patients who have tau, but it's the same story. We don't know where tau is without a PET scan, and we don't know whether its accumulation has been modified by a therapeutic intervention. So in both cases, I think their fundamental use is going to be to screen patients to see who would benefit most from a PET scan before entering a treatment paradigm.
Okay, yeah, makes sense. Now, over what time course do you expect Alzheimer's disease treatments to become widely available?
That's an excellent question. For a while, we were pretty impaired because Medicare, CMS, had decided not to cover either PET scans or these new therapies. But that changed last summer. They've opened the door to reimbursement for both the scans and the treatment. And I think we're going to see a very dramatic expansion in the use of PET scans to help enter patients into treatment with community neurologists. However, there's a barricade that we have to deal with, and that is these treatments require infusions, they require PET scans, and they require MRIs because there's a side effect to removing amyloid from the brain called ARIA, amyloid-related imaging abnormalities, that can be very serious and even lead to death in some patients. So patients have to be able to get PET scans and MRIs, frequent MRIs after administration, follow-up PET scans to make sure amyloid is being removed effectively, and potentially to determine when you can stop treating for amyloid therapy when all the amyloid is gone. And you need access to infusion centers. And right now in the United States, all three of those are pretty tied up. The infusion centers are busy with other treatments, mostly oncologic in nature. MRI scanners are buried and PET scanners are buried. So we're going to have an infrastructure expansion to allow us to use these therapies as widely as we think they should be.
Sure. And last question, what would you predict to be the next biomarker for which PET scans might be developed?
Well, my prejudices are on the slide in front of you. We've got amyloid and tau covered. Neuroinflammation is a really big deal, and we don't yet have good therapies, but we also don't have good biomarkers for neuroinflammation. We have widespread inflammation markers, cytokines in particular, but I think a PET scan, PET agent that would target inflammation, neuroinflammation specifically, would be really helpful, because I think we're going to, as you saw early on, have the ability to treat neuroinflammatory aspects of the disease. And then vascular disease shortly after that. We do have FDG, we have ways to measure blood flow with PET, and also with MRI, ASL in particular. So I think vascular disease targets are going to be either simultaneous with, not far behind, the neuroinflammatory targets.
Great. Well, thank you very much for these answers. We come now to the end of today's episode of BrainPet Talks. We would like to thank Dr. Devous very much for his interesting presentation. Thank you all for your interest. I'm looking forward to welcome you soon to the next episode of BrainPet Talks. Thank you so much. Bye-bye.